Hello, everyone. Am I audible?
Walaikum Assalam. Yes, Dr. Uzma, you're audible.
Thank you. Actually, I'm sorry. I have sore throat and cough, so please pardon me if I'm coughing a lot during the session. I'm trying to do it. We have how many people now? We have Iman, Bushra, Hanan. Okay, let's wait for some more people. In the meantime, can you introduce yourself, Iman?
Yes, I'm Dr. Iman. I am a candidate in part 3, but I get the exam in November.
Mm-hmm.
Yeah.
Okay, so you already appeared in the exam for November, or you're?
Yes. I attended the exam in November, yes.
Okay. How did it go, Dr. Iman?
I don't know. I did my best. That's it. But I don't know what is because after the exam, when I'm discussing with my colleagues and so on, everyone has some points. So for me, I did whatever I can do. That's it. So inshallah, I am hoping it will be okay. That's my hope.
Inshallah. Wish you all the best, Dr. Iman.
Inshallah.
Yeah. Okay. Then who else is there? Bushra. Bushra, can you open your mic? Bushra doesn't have a mic. Bushra, Deepa, Hanan, none of them. You have to activate your mic, please. Bushra, Deepa, Hanan. I don't know. Anyways. Okay, Iman, what were the stations in your exam? Where did you appear, in Abu Dhabi?
No, Osler. I was Osler.
Okay, all right.
Osler, not face-to-face, Osler, yeah.
Okay. So what were the stations? You felt it was
station,
different?
I don't know. My station was sexual assault, was high BMI, antenatal care, and also twins with many factors, many risk factors, single mother twins, high BMI, the BMI is 36, and has, it was 4 risk factors: high BMI, twins, briny, single mother, and this one station. And another station was bladder pain syndrome. And one station was intrauterine fetal death, stillbirth at 30 weeks, and has history of complicated previous cesarean section. And they put her under observation for induction of labor because of the intrauterine fetal death of the stillbirth, 30 weeks. And she has a high temperature and has very high C-reactive protein. It was like 60, the C-reactive protein. This also one station.
Look like very complicated cases for you.
Yeah. Yeah, it was. I did whatever I know and whatever information I know. That's it. But this one, especially this one, it was not easy. stillbirth 30 weeks and high fever and high C-reactive protein and previous complicated cesarean section. So it was, yeah, not easy one, yes. The other ones was okay, but this is the most
dangerous
complicated
one.
one. Yes, yes, yes.
Yeah. Okay, inshallah, no problem. Wish you all the best. Sometimes you feel that you haven't performed well, but you are actually doing well in the exam. And then once the aggregate comes, you are passed. So inshallah khair.
Inshallah, I am praying to God. Inshallah.
Praying for you.
Thank you. Thank you.
Okay, so we have now quite few number of people. So shall we start? Because we have Bushra, Deepa, Tripti, Hanan, and this one. Okay, shall we wait for some more time, or we can start?
Up to you, Dr. Uzma. It's up to you.
Let's start because there are a few people already we have joined in. What is the time now? Okay, let's wait 3 more minutes and 3:05 we'll start. Okay, in the meantime, we have Bushra, Deepa, Bhakti. Can somebody open their mic and introduce themselves if they have already set for the exam or they are going to sit in FAB only or next exam? Nobody want to introduce themselves?
Good afternoon, ma'am. This is Tripti. I'm going to sit on coming February, ma'am.
Okay, great, Tripti. So when did you pass your part 2?
2021, ma'am.
Okay, it's been almost
September. 2021 September.
Okay, so is this your first attempt?
Part 3, ma'am. Yes, it will be my first attempt at 3.
Okay, great. Good luck to you, Tripti.
Thank you, ma'am.
So just, we have made a group also on the WhatsApp where the FAB candidates are there. So we will be taking, regular sessions on each module for the FAB candidates, which will be free. So you can join that group and, be a part of that. It is going to be very helpful for you all.
Okay, ma'am.
All right. Okay, so Deepa, what about you? Yeah, Deepa, tell me. Open your mouth, Deepa. We can see you.
Hello, ma'am. I'm Shaista. Actually, I think some problem with her mic.
Hello.
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 Hello. Yes,
Hello, ma'am.
yes.
Can you hear me?
We can hear
Hello,
both
ma'am.
Shaista and other person also. I don't know who is that other person talking.
Yes, ma'am. I'm Deepa, and I have I sat for the once before in the May for part 3 exam, and I couldn't do that. So I'm trying for this fifth session, ma'am.
Okay. No worries. Inshallah, we are here to help you and guide you. Join our group and we'll be guiding you people. And there is always, whenever you are sitting for exam, it is in itself a challenge and you always learn from exam. Although you feel demotivated once you are not able to go through it. But anyways, it is always you're adding to your knowledge. So inshallah, next time you will do it. Don't worry about it.
Thank you so much, ma'am.
Yes, Shaista, we were able to hear you.
Yes, ma'am. I'm Shaista. I appeared once in May 2022, but actually some of my family issues, so I was not very well prepared for exam. So now now I'm planning to do that.
Okay, no worries, Shaista. Inshallah, prepare well this time and you will pass. Okay, I think we should start now. Yeah, Nahid. Yes, Nahid. Can we hear from you? Okay, you didn't take part 3. No problem. So you are going to appear when, Nahid? Your mic is not working? May. Okay, okay. No issues. Okay. Okay, so let's start our session. As you know, this is today we will be talking about clinical governance. Clinical governance, many stations are coming in the part 3 exam, and they are coming in different ways. So you might see it as some complication of the surgery that has happened. So there, what you will do, you are supposed to do is identify the problem, what will be your immediate management, and what you will do later. So it can come as a mistake topic, somebody you saw in emergency and you sent her home, and then patient comes back, collapsed, that's your topic. So then there is investigation going on. You have a meeting with your clinical director, or it can come as somebody who had a LEDS procedure and she's pregnant now. You didn't offer her a cervical stitch, and she comes with a miscarriage after 16 weeks. So she is putting the blame on you that you did not offer her the cerclage, and that is why the baby fell down. Or you are performing, suppose, evacuation, and you end up rupturing the uterus, perforation is there. So then you have to write an incident report and what factors you will avoid, what more clinical sorry dear, knowledge you need, what more training you need so that these things don't happen in future. And then they combine a reflective practice with this clinical governance, where whatever has been done, you have to write, do a reflective practice on it and put it on your e-portfolio. So how we define clinical governance? Clinical governance, it is a system through which NHS organizations are accountable for continuously improving the quality of their services in safeguarding high standards of care by creating an environment in which excellence in clinical care will flourish. Okay, so it has 7 pillars. Any idea about the 7 pillars of clinical governance? Anybody?
It's
Yes,
ethics and
yes.
documentation, debriefing, the ethics, that is incident reporting, and drills and reflective practice also is there, ma'am. And
Okay, we are
DBT
talking,
risk assessment.
okay, so we are talking about 7 pillars of clinical governance. Okay. Anybody else want to add?
Ma'am,
Yes, we
audit,
can add,
audit,
we can
Aud-
audit, yes, we can add audit here.
Okay, so these are actually the 7 pillars where you do a risk management. There is education, training, and continuous professional development. There is audit. There's clinical effectiveness, information management and communication, patient and public involvement, and strategic leadership, workforce, and performance management. Okay, so these are the 7 pillars of clinical governance. So why you need clinical effectiveness? Why? Because we should be sure that right person is doing the right thing. So the right thing, that is evidence-based practice, in the right way, that means skills and competencies are there. At the right time, like providing treatment and services when the patient needs them, not the wrong time. Right place where this treatment should be taken. and the right result. That is clinical effectiveness, maximizing health gain. So best available evidence, clinical skills, and patient preference are combined to achieve the optimal processes and outcome. Understood?
Yes, ma'am.
So these are, yeah. Any question? Okay, so we'll talk one by one about them. So once we are talking about the clinical effectiveness, it means that any treatment which you are using must provide the best outcome to the patient. So you're using evidence-based approaches when deciding on the treatment. You stick to the guidelines, you use experience to improve, and there should be research that to enhance future care. Okay. Then comes risk management. So risk management, you have to minimize the risk in patient care. There are different ways to manage a risk and ensure that incidents, they don't occur. So what are those things? You should identify problematic areas in the treatment. You should improve through learning from the previous issues. You reduce the risk by implementing the risk systems, and you look at the risk management module of your hospital, wherever you are working. And you should do a thorough risk assessments and report the incidents and near misses. So this is very important to write incident reports, because incident reports in the NHS, they're not taken as something which is writing against you. It is there to improve the healthcare system. Okay. Then patient and public involvement. You have to communicate with the patients and the public to gain insight of the quality of care and any possible problems. You should have patient questionnaires, patient forums, and representatives of the patients and practice in hospital boards. Okay, so once you are going for the exam, you see sometimes there is a station where another examiner, not examiner, a lay examiner is sitting. You know who is he? Anybody?
Ma'am, yeah, lay examiner is a person from the community who is not related to medical specialty, but he knows and he will check how we are communicating, how we are empathetic with the patient. Basically, he will check our communication with the patient.
Exactly, very good. So this station has the maximum marks because he's a lay person. He's just looking from the perspective of patients, how patients will feel if they come to you. Okay, so this is the patient representative from the NHS. Okay, then we talk about audits. The audits are carried out to monitor the quality of clinical care being carried out. They measure against the set guidelines and deviances which are examined and improved upon. After sometimes audits are repeated to ensure that actions taken to improve have worked and organizations are quality assured. So if you see something is happening continuously in your hospital, and then you identify that problem, you implement some changes against, and your this will be your guidelines will be there. So you then measure your practice against those guidelines, and then you do a re-audit to see if the changes that you have implemented are working and they have led to any improvement in your services or no. Okay. I'm really sorry for this bad throat. Then you do a staff management. Staff management means you ensure the employed people, they carry out their work. And if somebody is underperforming, they can be highlighted and helped to be improved. And there should be professional development of the staff. This should be, they should be helped through motivation and pleasant working environment. So continuous professional development and staff training is very, very important in clinical governance. Then comes the education and training. So if you identify certain people, they are underperforming or they're making continuous mistakes in certain things, then you arrange for them special education and training courses so that they improve their skills. And then patient information should always be up to date and correct on any systems used. It should be confidential through correct storage and management of the data. Okay. Any questions till now? No questions? Okay, so why do you think these 7 pillars of clinical governance are important?
For good quality care of the patient, to keep an eye on the system. I mean, analyze the system where we are lacking the things and where we are doing the mistakes. What are the avoidable things and what are not avoidable?
Yeah, exactly. Very good. So clinical governance ensures a continuous drive to improve the standards of health and social care organizations. This is a cycle of controlling, monitoring, and improving through all these pillars to ensure a high quality of care to the patients. Okay. So let's talk briefly about the audit. So audit, it is a clinical quality improvement process that seeks to improve patient care and outcome through systematic review of care against the explicit criteria and implementation of change. So this explicit criteria is what?
Like the GTG or like the GMC regulation, those are standard. We are referring to them or comparing our data or our results, comparing with those standards, like the GTG or like the GMC rules or like NICE guidelines.
Exactly. So either you have your own protocols in the hospital, and your own protocols also should be against some international standards. So very rightly said that the international standards are either the GTG guidelines or the NICE guidelines or where they are following the European guidelines, ESHRE guidelines, so those ones. So you should have a standard international protocol against which you check your own performances. Okay. So this is radar health. This is also something which they follow in NHS. So let's go to determining best practice. So best practice is what do we want to achieve from our clinical audit? What you want to achieve from clinical audit? Anybody want to comment?
Yes, if we get a result, for example, there is a lot of cesarean section, for example, in our hospital, and we need to know why the cesarean section is more than the percentage with the standard percentage. We must do audit to check for what is the causes, what is the data, what is the collection of information we are collecting to know about the causes, and also about the all the circumstances for the cesarean section. Is it a defect in the training? Is it afraid of legal questioning about instrumental delivery, or it is lack of skill and drill in the instrumental delivery, or it is unidentification of breach presentation early. A lot of factors. So we are searching, doing the audit to check why our percentage is high than the standard percentage, so we can implement the changes. If we need to do some training and education for the junior staff to do more instrumental delivery, and also those changes we will distribute it through all the maternity staff. And also we will compare the result after we implement the changes, and we will do re-audit again.
Okay, very well done, doctor. So
Thank you.
she touched everything what I was about to tell you. So as you can see that first of all, you should have a goal, what you want to do. Like this is also one station which keeps coming in the exam, where they show your maternity dashboard, and you can see that your the cesarean rate is coming high. So then they ask you, why do you think it is coming high? So your instrumental deliveries are coming low, and then cesarean rate is coming high. So you identify that maybe the people, there are junior people on duty in the night, the seniors are not available. So you can suggest that senior, like a consultant, should be available on the floor. There should be more training for people to perform instrumental deliveries. And like she said, a breech, identification of breech presentation and offering her an ECV in the antenatal period will avoid a cesarean section in this pregnancy. So these all things, and they will take you one by one, what you see and how you're going to improve it. And then once you have put all your things together, then they say, okay, how you will measure? You will do a re-audit again. Okay. So benchmark, we already discussed. These benchmarks are the international guidelines which we will follow. Then results will be shared with all the stakeholders, and if non-compliance is presented, underlying causes must be found. An action plan must be created to address the underlying causes. System improvement should be proposed to reduce these, and the action plan must be actioned and the results monitored. Okay, and then you have to sustain the improvement. So are we keeping our standards? So this is the audit. You will check if whatever changes you have implemented, is the team following all those changes or no? Okay, and there is Care Quality Commission, which is an independent regulator of health and social care in England. They monitor, inspect, and regulate the services in the health and social care industry. By doing this, they release ratings, which help the public choose which organization they would like to use. Okay, so each hospital, they will have affiliation with these. If they are like, JCIA we have in UAE and other places. So this Care Quality Commission, they will visit the hospitals, they will check them, and they will regulate the services, and they will give the rating for the public if they okay, good to go or no. Okay. Any questions till now from anyone? Okay, so you see that they are checking 5 things during inspection. Number 1 is, are they safe? Is the hospital where a patient goes, or the doctor where the patient goes, is that doctor or that organization is safe? What it means by safe? It means that you are protected from abuse and avoidable harm. Then how can you protect the people from abuse? How are the risk and safety monitored to ensure people's freedom is respected? How do you ensure that proper and safe use of medicines is there? How well is everyone protected by the prevention of control of infection? Are the lessons learned, improvements made when something goes wrong? So you understand that when a patient comes to a hospital, every patient is coming with a different belief of her own. So that belief should be respected. Then the medicines which you are giving to the patient, you should be 100% sure that are these medicines safe for that particular patient or no. And then the infection control policy should be in place for the hospital to prevent the occurrence of infections. And if there is some incident happening in that hospital, is there any system in place to check and balance so that this incident doesn't happen in future? So these all things. So are they effective? Effective means that your care, your treatment and support, it achieves good outcomes. It helps you maintain quality of the life, which is based on the best available evidence. So if the care delivered in line with legislation and evidence-based guideline, how do you ensure your staff have the knowledge to deliver the effective care? And how well does your organization as a whole work together to deliver effective care? Then caring means staff involved should deal with the patients with compassion, kindness, dignity, and respect. And we should be sure that people are treated kindly and provided with the emotional support. And people support, you should support people to be actively involved in making decisions in their care. So, you know, especially this slide, if you see, you are talking, once patient comes to you, you will take her history and you will say that, okay, I will give you patient information leaflet at the end of the session. And if required, I will refer you to some patient support system groups. So these all things, these are very, very important in the NHS framework. Okay. So once you are saying all these words, you are ticking the boxes which they expect from you. Okay. So are they responsive to people's need? Responsive means services are organized so that they meet your needs and the concerns and complaints are handled to improve the quality of care. And then organization is well led or no. So the leadership, the seniors, if the management is good, the governance of organization is up to the standard, and they encourage learning and innovation. It promotes an open and fair culture. So this is very important, that the management who is leading the hospital, they are also following the quality standards. Then these are the few questions they ask by the risk management. So once you are thinking about a risk, then first thing which comes in your mind is what can go wrong. So what can go wrong means you are trying to identify the risk. Then what are the chances of it going wrong, and what will be the impact? That is risk analysis and evaluation. Sometimes the risk is very, very small. So it can be, you know, taken lightly, but sometimes of something you will do has a very big impact on the patient and on the organization. So that is a big risk matrix, we call it. So then you really have to be very, very careful. Then what can we do to minimize the chance of this happening or to mitigate damage when it has gone wrong? That is risk treatment. The cost of prevention is compared with the cost of getting it wrong. So here what they do is, suppose they will implement a change, the risk is very small. Suppose this is just an example, and they implement a change and the cost of implementing a change is very high against the risk that is happening if we don't implement that change. So do you think it should be happening, or you think no? Anybody? No? Okay, good. Yeah. So if you have to, you know, NHS is very careful with the money expenditure. So they don't like, even in the exam, that you should talk about unnecessary investigations for the patient. Okay, just to, that's why if you say any investigation, they will say why you want to do this investigation, what are you looking for. So be very careful once you are answering and you are trying to tell that I would like to do this investigation or that investigation, because they are really bothered about that unnecessary expenditure. Then what can we learn from things that have gone wrong? So that is your risk control, where you share and you learn. Okay, I hope this risk management is clear. You can open your mic and please say.
Clear, Dr. Uzma.
Sorry. Okay, thank you. So then post-operative management complications. Post-operative complications are possible following surgery. So what they expect from you, that you should have a rapid recognition and you should know how to manage the complication. This is very, very important for the clinicians. And identification of the risk factors preoperatively, individualizing the careful planning and use of prophylactic drugs, such as antibiotics or anticoagulants that can decrease the potential complications. Okay, then I told you about reflection. So reflection has three components. It is a systematic approach to thinking that has a purpose, goal, or outcome. It is influenced by the context in which it is being carried out. It is like a self-awareness thing. It is a process of analyzing, questioning, and reframing an experience to make an assessment of it for the purpose of learning and improving your own practice. It is often described as disciplined self-surveillance. So can anybody open the mic and give me an example of reflection?
Yes, like if I'm doing D&C or I'm doing laparoscopy and I get perforation with the uterus, and we get repair of this perforation, or we give antibiotic and we put her for under observation, I must do reflective notes about what happened and what is the causes for this incident, and how to avoid it, and what did I do to not to avoid it in the next time if I did something with no intention or something. How can I avoid it again? And I must share also this reflective notes with all my staff to share the experience, how to avoid uterine perforation or how to avoid any other complication.
Exactly. Very good, doctor. So why should we be reflecting? It is often perceived as a retrospective activity. That is, you're thinking back or you're reviewing what has happened. So although it has a proactive component that you make sure that you are more prepared for the next time, and if you encounter the same problem, either professionally or personally, and this is a part of continuous learning process in which the new knowledge can emerge. So suppose you tried to do a vacuum delivery in labor room and you didn't apply the vacuum properly, and it is a failed vacuum. You take the patient to for cesarean section. It is a second stage cesarean section, and patient has an extension and a postpartum hemorrhage. So now you are thinking back. Now you want to learn of what you did wrong in that vacuum. If the head was down, was I able to apply vacuum at the right place? Was my was that patient really a candidate for vacuum delivery or no? And if I need more training on instrumental delivery, should I inform my clinical director? So these are the things how you reflect on your own practices. Okay. Then comes the incident reporting. So incident reporting should be surgery can sometimes lead to complications. So whenever you are having a station like this, where there is a complication, so please make sure you talk about 4 Ds. DETICS is the incident report, is call it DETICS. Documentation, that is you document everything that has happened. And debrief the team and the patient. And duty of candor, that is you go and apologize the patient and it's just explain in detail, honestly, what actually happened. So as I said, incident reporting should not lead to a blame culture. It should encourage reflection on how the outcome can be improved. Okay. Anything else? Anybody want to say anything? Okay. So what is a reflective ability? It is the ability of how we think purposefully about a clinical or educational issue. It is influenced by the context of why and where it is being done. And is it influenced by our own value system? It increases the effectiveness and efficiency of learning as a clinician and educator. It enhances innovation and it improves accuracy of the decision making. Okay, and there are different ways of doing this reflective practice. There are frameworks. I will just talk about few frameworks here. One is John's, one is Squares, and one is Kerr. So these all are mentioned in the strategy. So they showed one cheese model. Is here they were talking about one patient who came with sorry, respiratory distress, and they identified what were the problems that happened in the management of that patient. So there was a problem in communication, there was lack of supervision for the patient, then the training staff was undertrained, their skills were not up to the mark, and the ventilation was not working, patient monitoring was not done well, and as a result, patient developed acute respiratory distress. Okay. Then as briefly, you can say that reflective cycle is number one, you describe what has happened. Number two are the feelings, what you are going through. Once something has happened by you, then you evaluate, then you conclude, and then the action. Okay. So if I have done some mistake, I will just describe what mistake is done by me, and then how I feel after doing this mistake. Then I evaluate myself, why that mistake was done by me. Then I conclude. Conclude means I will see that what were the loopholes in my training on that particular day when the incident happened. So I will put all the things together. You conclude the incident that has happened, and then what you will do to avoid it happening in the future. So this is your reflective cycle. Okay. So these are different models where, as I already said, that you describe your experience, why you were trying to achieve and how did you feel, what were the factors that influenced your decision, and is there any better way of dealing with that situation, and what have I learned and how do I feel. Okay, any questions so far? Okay. Are you people following me, or no, it is something very boring for all of you?
Ma'am, it's
No, it's
really very
okay.
interesting,
It's
ma'am.
clear, Dr. Uzma.
Okay, okay, all right. Thank you very much. Okay, who would like to take the task?
Okay, I can get it, Dr. Uzma.
Iman?
Yes, yes.
All right, okay. So this is, okay, so we will exactly do it as in exam we are doing. You have 2 minutes of reading time and you have 10 minutes of performance, okay?
Okay, okay.
All right, so let me put the timer for you, 1 minute. Okay. Okay, this is your task, doctor, okay? Once you want me to show you the next page, just let me know, okay?
Still, I didn't see. I have on. Yes, okay. Now I can see.
Yeah.
Okay, there is next page, next slide. Yes, okay, next slide.
Uh-oh. No, nothing. That's it. You have only
Okay.
one slide of the picture and this is your case.
Okay, okay.
You have 2 minutes, Dr. Iman. So just take your time, arrange your thoughts.
Dr. Uzma, just I will answer. I am in the clinic. I will answer, and I am with you. I will just tell them not to disturb while I am in the.
Okay, no problem. Fine.
Just a minute.
Okay,
Hello?
okay.
It's okay, Dr. Uzma. I'm with you.
Okay, we have still
I'm
25
ready.
seconds.
I'm ready.
No, no.
Yeah. Okay.
Okay.
I'm ready.
You are
Okay.
ready? Okay.
Yes. Yes.
All right. Okay. So, doctor, what do you think has happened? Okay, you start the station. How you will start the station?
Yes, I'm Dr. Iman, exam candidate. I read the instructions and I'm ready for the structured discussion.
Okay. Hello, doctor. So, what do you think has happened, doctor, here?
Here we are doing laparoscopic sterilization of 40 years old female, and there was a uterine manipulator, and I think there is perforation. Uterine perforation has happened during the laparoscopic sterilization. Yes.
Okay. So, what you will do now, doctor?
I will get help. I will stop the procedure of the sterilization. I will inform all the staff of the operative theater. I will inform the anesthesia doctor to get antibiotic and to be ready for the long, maybe we will get longer than the planned time. So all the staff in the operative theater must be ready for a longer time, must be ready with the medication or the instruments which we may need. I will inform also my consultant, and I will inform until the consultant is coming. If the consultant is there in the operative theater, he will explore with me what is the site and the size of the perforation. If it is a small perforation, we will just make observation. If there is no more bleeding, we can complete our procedure about the sterilization, and we will just watch and observe the site of the perforation. If there is no more bleeding, we can leave it. We can give antibiotic, and then we can observe. And if it is a big one, or the site it is near to the broad ligament or need to the vessel, a blood vessel, we must repair it, and we will repair it, and we will be sure about the hemostasis. There is no more bleeding, and we will cover with a course of antibiotics, and we will also complete the procedure of the sterilization. But first, I must stop and inform my consultant, inform all the staff of the operative theater, inform the anesthesia, all the nursing staff, the scrub nurse, everybody, to be sure everybody is oriented what had happened, and to be ready for our repair of this perforation.
Okay. Anything else you would like to say in this patient after the perforation has happened?
Yes, I will check her vital signs. I will check about if there is any bleeding, and about the vital signs, the blood pressure, the pulse, the urine output, and I will monitor all her vital signs through Meow chart or through our chart to be sure there is no deterioration in the vital signs and there is no more bleeding. And I'll be sure the antibiotic is given, and with the right dose and right prescription, and there is no allergy for this antibiotic for the patient. And I will monitor her after the procedure to check if there is no deterioration, no more bleeding. She can go home, and then she can come after for follow-up. If there is more deterioration in the vital signs, we can get back to the operative theater to check maybe there is no good homeostasis, or there is another injury we didn't realize it, because we must also check and explore all the pelvis if there is any other injury to the bowel, to bladder, to other blood vessel or not.
Okay, so if you encounter damage to any other organ, what you will do then?
Also the same, I will inform all the operative theater. I will inform my consultant. I can inform also if it is a bladder or a bowel injury. I must inform also the other specialty, like the urologist or like the gastroenterologist doctor if it is bowel injury, and I will inform my consultant. And according to the injury, I will check my consultant can do it by himself, or I can do it under the observation of my consultant. Or if it is more complicated or needs more specific management, we can get the help from the specified doctor, like the urologist or gynecologist or the gastroenterologist, to help for the management of the injury. And also we will inform all the staff. After the operation, we will do the incident report, we will do documentation, we will do reflective practice also about our what had happened and why. And I will share all the reflective notes with my colleagues. And also we will do the incident report, we will do the duty condor with the patient, we will inform her with a transparent information or everything had happened, and we will apologize for this complication. We will do risk management through what had happened and why it happened. We will analyze the data and we will do investigation, what is the defect or what is the causes, and we will try to avoid it and treat it. We will do more drill and skill and drill in the procedure for all the staff who needs this education or training. And we will give the patient also the result of the risk management team through this process, to be in the duty of condor with the patient. And everything will be documented, and the patient will be well debriefed.
Okay. What about this ST1 who was doing your help with the manipulator?
The ST1, I will not do a blame action with him. I will do the reflective practice with him without blaming, just as what had happened and why it happened. We must get ready for the next time to avoid the reasons for this complication, but without blaming of the junior trainee. And also we will do the reflective practice and share it with everybody, including the trainee, but without blaming of him.
Okay, so what are the common sites of uterine perforation, and if you can give me incidents also?
Yes, the common sites, it is the anterior wall, it is about 41%, then the cervix, it is 36%, then the right and the left uterine wall, it is 21, the right wall 21%, is the left one 16%, then the fundus and the posterior wall, it is 13%.
Okay, and with which instrument there is increased chance of having a perforation?
The suction evacuation instrument, then the dilator. The first one, 51%, is the suction evacuation device, and the second 51%. and the second one is the dilator. It is about 26%,
Okay.
as I
Any
remember.
risk factors which will increase the risk of perforation?
Yes, the risk factors for perforation, maybe we didn't get the anatomical map of the whole pelvic area, and also the use of the thermal device or thermal instruments without proper insulation or without proper training, and also in the postpartum or postpartum uterus, and also abortion uterus. This is especially in the second trimester.
Time finished, Doctora.
Yes.
Time finished.
Oh, thank you. Thank you.
Okay, okay. Very, very well done, Dr. Iman. I'm really impressed.
Thank you.
Okay, so before we discuss the topic, anybody want to give a feedback to Dr. Iman? Please open your mic and give the feedback. Start with the good points always.
Can I use my?
Yeah, please speak little louder.
Yeah, she presented, she discussed the case very well. And she picked almost all the points which we need to discuss in this structured discussion and even in a clinical practice. One or two more points like it is the situational awareness also, because the perforation had happened with my ST1. So, and I am doing the laparoscopy and I am the exam candidate. So I will start like that it is under vision. So we will remove the, I will ask my ST1 to remove the manipulator, and the problem has happened and perforation has happened, and then under vision I will see how much patient is bleeding and how large the perforation. Sometimes a small rent less than 5 millimeter will seal it by itself, and then we will remove the laparoscope, whatever repair, and she involved everything, everybody, that other organs involved, like bladder injury or the bowel injury we have to exclude. And she comment about anesthesia also, that also we should do. Other thing is the counseling of ST1 and debriefing to the patient, because this ST1 will be, we can arrange a session with her to counsel her, because she must be upset, she or he, and we can arrange a session and we can like do a educational class with her and training or educational. Other one is debriefing to the patient, which she covered on patient report. So because I am doing the surgery, so and I am under vision, I am doing laparoscopy, so I can see everything, and then of course involvement of consultant and all. Only I think this thing needs to be added.
Okay, okay, yes, I agree with most of the points you raised. Anybody else want to comment? Okay, nobody else want to comment. Okay, all right. So Iman, as I said,
Yes.
it is a very nicely performed station. You covered almost everything in this station. It was my station in my part 3 exam. The picture was not like this, where you can exactly identify this perforation. It was a manipulator perforating the uterus. So there were so many people who were unable to identify what actually happened. Okay.
Yeah.
So you have to be very, very, alert in the exam and try to understand each and every page that is provided to you. Because if you don't understand this perforation, then your station is gone, right? Because we
Yes.
don't know what is there, what they are mentioning.
Yes.
Okay.
Yes.
So first she asked me that, okay, what is your diagnosis, what happened. So I told her, yeah, there is a perforation. Then she said, okay, what you will do now? So as you said, first of all, I will stop the procedure. I will inform the anesthetist that I'm suspecting a perforation in the uterus. And I will inform the circulating nurse to call and inform my consultant. So because we have a complication, and I will inform my nurse also, the technician, that we will need extra instruments because we might need to open the patient. Okay. Then she said, okay, what else you would look for? So you came to this one in a bit late, that I want to see, because this is full perforation. So you have to identify, is there any other organ involved? Any gut is there? Any bladder is there? So once your consultant comes, that consultant will decide if you need a colorectal surgeon or you need a urologist to repair, because sometimes it is a small perforation that your consultant can manage. So let the consultant come, review, and then decide if they need additional support from the colleagues. Okay. So this was another thing. Then as she said that this perforation is not done by you, it is done by the ST1. So you very rightly mentioned that you will not put a blame game. But of course, that ST1 is a fresh trainee. She or he will be under a lot of stress after doing this perforation. So she needs support. There should be a meeting with the clinical director or the educational supervisor. And you should also be careful that if you are taking a junior with you, you should ensure that has this junior performed this task before or no. Because you are taking her, so this is your responsibility also. So these were the things they wanted us to highlight. And then she said, okay, what else you will do? So after all this, you will, as you covered everything, incident reporting, duty of candor, documentation, debrief, and then you will, not you, because this is not done by you. It is ST1. So she is going to, go with the e-portfolio where she's going to do reflective practice and write it on her e-portfolio. Okay. Any questions?
Yes. Thank you.
No problem. You are welcome. So then they ask about that. Okay, these questions which I asked you, that this is from the talk. So they asked that what are the common sites of perforation? You covered everything very nicely. And what are the instruments? This is basically with the suction evacuation, but they want to ask these questions. They just want to know your background knowledge about uterine perforation, with which instruments it can happen more. And then this was the question I asked you, but the time finished. So advanced gestation, when termination of pregnancy is performed, evacuation for postpartum PPH, multiparous uterus, patient has been pregnant in the past 6 months, or it's a small menopausal uterus, or it is a tight cervix, or uterine cavity is restricted because of some fibroids, there are some adhesions, there is infection, how is the uterus, anteverted, retroverted, or acutely retroverted, anteverted, any anomalies of the uterus are there, or there are previous surgeries on the uterus. Okay. Then management part you covered very well, that management of uterine perforation depends on the procedure being carried out. And one more thing she asked me, that what you will do, you will proceed with the sterilization or no? So of course you already covered that you will proceed with the sterilization. Sterilization you will complete, and the remaining things you will look for if she needs to be on conservative treatment, on observation, or you need some active treatment if there is an active bleeding or involvement of any other organ is there. Okay, any questions by anyone so far?
Thank you, Dr. Uzma. Thank you to give me the chance. Thank you.
You are welcome, no problem. Any questions by anyone else, please feel free to ask.
Ma'am, can you kindly please tell about the communication with the patient and her family?
Yeah. So as Dr. Iman covered that once the procedure is finished, the patient, according to her condition, if she needs a high dependency unit, she will be shifted to the high dependency unit, and you will go to the patient and you will inform her. First, you will apologize for what has happened, and you will explain that this, unfortunately, you can say that I'm sorry that during the procedure, this is the complication which happened. We made a hole in the uterus, but it is a known complication. So she also asked about consent. So what consent you have taken from the patient. So the consent should mention all the possible complications, because that consent is going to save you. Okay. So this is a possible complication. So I'm sorry that this has happened, but we were able to identify it on time and we rectified the problem. It required surgery or it didn't require surgery, but whatever you did during the surgery. So you tell her that we were able to suture the uterus, and we checked carefully if any other organ was involved or no, and we ensured that the patient is well before we close the abdomen. So we will investigate. We have already raised an incident report and we will do an investigation, and we will keep informing you. I will arrange another appointment for you with my consultant, and we will keep you in the loop of this investigation. Okay, this is how you're going to tell the patient and the family. Clear?
Yes, ma'am.
Okay. All right. So as I said that she asked me what else you will see. So you will look for any associated injuries. You will keep the patient in the hospital. You will observe according to the situation of the patient. Either observation is required or some intervention is required. So maybe if there's a bowel injury, you need to, involve the colorectal surgeon. And this is again from the TOG article. So what type of instrument was used and what you need to do. If immediate management is the alert the team, you put catheter, you observe, you start antibiotic, you ask for the senior help. And then if there is no bleeding, patient is stable, you can do just conservative management. Or if the patient is bleeding or the patient is unstable, then you either, this is because this one is with the stereoscopy and evacuation. That's why they have mentioned laparoscopy here. The station in this one, you are already with the laparoscopy. So you might need to start laparotomy for her as per the perforation size. Okay. And this is the risk management part, which Iman covered nicely. This all is mentioned in the talk, and they expect you to, know these things very clearly, because if you are becoming a member of MRCOG or RCOG, then they expect you to come and practice there. So you should know their system, what is going on in their system, so that you are a safe doctor for them or no. Okay. Any questions about today's session? No questions? I hope things were clear to you.
Thank you very much. The prayer is much clear.
Okay, thank you so much. So as I told that we are doing this one 1:1 mock and course of for the FEB candidates with small batches, because I don't like to have too many people and they're not able to perform during the session. So anybody who is interested to join, please contact our technical team and they will guide you further. Plus, we are having a free group for the FEB candidates. So please join there, and we will be doing weekly or within 10, every 10 days free sessions there. participate in those sessions. It will be a real great learning experience for all of you. Okay. Anybody would like to give me feedback how they felt about the session today?
Thank you. It is very helpful and very valuable knowledge and information. Thank you, Dr. Uzma.
Thank you so much, Doctor.
Excellent, ma'am.
Thank you, dear. So I am available whenever you want any guidance. Please feel free to contact me at the Med Exam group. Okay, and inshallah, we will be having more sessions, and we will try to help you and support you in your journey to finish this RCOG exam, because I think this is the most difficult exam of all. The RCPI and the MRCOG, it is nothing as compared to RCOG, because there's a lot of knowledge and 14 stations and patient handling. So it's just not your knowledge. It is so many things that matter to pass this exam. So we are here to help you. Please feel free to contact us. And I'm really sorry for this cough and sore throat. I'm still running fever, but I tried to, manage the session today. Thank you very much.
Thank you, Dr. Uzma, and to have a good health, inshallah.
Thank you.
Dr. Uzma, I
Yes.
just want to ask how much the percentage of repeated task in the exam, in the real exam?
Too much. You see, mostly they are recalls, mostly. Maybe hardly you will see 1 or 2 news stations. But the thing is that number of stations is also too many, no? So maybe we have already 90 stations. So most of them are recalls.
Yes.
Even so, if you are well prepared with the stations, they might, just create a little twist in the station. They will just change something slightly, but the main topic remains the same. So what I believe in that, because once I was a student, I also took courses, and I saw people running after the templates, and they want, shortcuts to pass the exam. That way you will not be able to pass exam, because you have to know the topic. Once you know the topic, it comes with the twist, it comes whatever way, you will be able to handle it. This is the most important thing. So please, whenever you are preparing a topic, don't go with the template only. Just go with the topic. Suppose it is a premenstrual syndrome. So you prepare your premenstrual syndrome topic, full topic. So now it comes whatever way. There might be little twist here and there, but you will be able to manage it for sure. But if you start going through the, shortcuts, and there are people who just try to exactly copy the words of their mentors, it doesn't work. You are an individual in yourself. Please be yourself, do your own hard work. We are there to guide you, but don't become clones of the mentors. Just put your knowledge together and you will definitely pass.
Yes. We can have more information about your course, please?
Yeah, sure. I will just, sorry. My sore throat is killing me now. My team will just contact our team, and they will let you know about the details of the course, okay?
Okay. Thank you very much. Take care, Dr. Uzma. Thank
You
you
are
very much.
welcome. You are welcome, dear. Okay, thank you so much, everyone, for joining us. And I hope I was able to add to your knowledge. And inshallah, I'll see you again in the next webinar, which will be soon. Okay, thank you very much, and have a good day, all of you.